So at the outset, I'd like to thank the organizers, chairpersons, Dr. Khalik, and members of the MPAI for inviting for inviting me here. It's very difficult in a span of 20 minutes to talk on molecular monitoring for all three disorders. So I'm going to focus on ALL, on acute myeloid leukemia. So as some of you may know, acute myeloid leukemia actually results from a clonal expansion of blasts. And this is conventional old school thinking that that uh, except for acute promyelocytic leukemia, AMLs can be classified based on cytogenetics into favorable, intermediate, and unfavorable genetics. In the last few years, we have seen an explosion of technologies in the previous decade based on the microarrays, and in the last decade, it has largely been driven by developments in next generation sequencing. So these have led to changes in the way acute leukemias have been classified, starting from the FAB classification of AML to the current WHO classification, which is heavily dependent on genomics and as well as some other investigations. As compared to various other solid tumors, you can see that AML is actually mutationally less complex. So if you compare this to breast cancer, or if you compare this to lung cancer or melanoma, the number of somatic mutations in AML are few. Even if you split this AML based on cytogenetic or based on cytogenetic abnormalities, we see that maximally the number of mutations which are present in AML with intermediate risk. That means patients who don't have patients who have a normal karyotype. So in the beginning of the last decade, we had a lot of discovery studies which looked at whole exome sequencing of cancers, largely led by the TCGA project. And subsequently, we understood that AML had a fixed amount of fixed pathways that got involved in mutations in tumor suppressor genes, in DNA methylation pathways, signaling pathways, chromatin modifiers, myeloid factors, transcription factors, cohesin complex, spliceosomal genes, and so on. And subsequently, people realize that you don't need to study the entire genome or the coding genome, and you can focus on smaller panels. Now, this is data from our hospital, which we studied on a large cohort of AML, saying that when you use these targeted or focused panels, you can identify one mutation in at least 90% of the patients. So the next obvious question is, can you perform panel-based next generation sequencing to monitor the disappearance of these mutations in the context of chemotherapy? In other words, can this be a surrogate for monitoring of residual disease in AML? Before we talk of monitoring of residual disease, one of the important phenomena that we must understand is age-related clonal hematopoiesis. So this was done on large cohorts of patients which were actually for heart disease and as well as mental disorders, where they found that as patients started to age, you started to get mutations which are in hematopoietic genes, well-described hematopoietic genes, and these were typically genes such as DNMT3A, TET2, ASXL1, TP53, and we call this phenomena age-related clonal hematopoiesis. The difference between ARCH and CHIP is that CHIP includes genes which are exclusively present in myeloid pathways, whereas ARCH is a much more broader term which includes other genes as well. What people found over time is that they occur early in the context of AML therapy. That means CHIP originates early and subsequent somatic pathway mutations take place. These mutations, even when the patient is in morphological CR, they persist. And the only way they can be rid of is by transplanting the patient's bone marrow. So if you do a bone marrow transplantation, these chip-associated mutations persist. But this actually has major implications for MRD monitoring. So we published this data some years ago on NPM1 mutated AMLs, where you can see that these patients which have NPM1 mutations also have DNMT3A mutations. And you can see that with therapy on the right side in plot B, although NPM1 mutation VAPs are decreasing, the DNMT3A levels persist. So indicating that these are not very great markers or not very suitable for MRD monitoring. So this is a landmark paper. This was published by Peter Fox group, which showed that that if you exclude the DTA mutations or mutations in DNMT3A, TET2, and ASXL1, the rest of the other mutations are predictive of outcome. That means if these mutations are present, the patient, you can use this as a surrogate evidence of MRD, and those patients were more likely to relapse. But unfortunately, this is not so mm, straightforward as taking a bone marrow and just sequencing at a very high coverage. This is because most of the short read sequences that there are, such as the Illumina sequences, they're associated with errors of sequencing. That means you can get these random errors which are present, as you can see in an IGV plot. So this is the reason why actually variant collars or most of your clinical NGS assays have a limit of 3 to 5%, because the because the variant callers use statistical algorithms below which they cannot say that this is a true mutation or this is an MRD artifact. To the way that initial papers overcame this is by doing something called as position specific mm, position-specific modeling of errors, where they assume that that an NGS error operates in the ballpark of 1%, and at every nucleotide there is a fixed possibility of errors that arrive, based on which you create a distribution. And if there is an error outside of that expected frequency, you can call that mutation or not. So it works in theory, but it is not very greatly reproducible. So the subsequent papers that came, or subsequent direction of science in the field, was to use something called as error corrected sequencing, or UMI, or unique molecular index based sequencing, where you introduce a degenerate barcode or a molecular barcode in every strand of DNA. So this can be done by some techniques such as PCR. This can be done by technique known as molecular inversion probes. Today, you can use this some other approaches to do it. So one strand of DNA actually gets this UMI incorporated. When you do PCR, you can see all molecules that come from one specific UMI can be collected together on bioinformatics, and you can spot these errors of sequencing which are here. So the consensus call for every read, these errors get removed, and you can do actual very accurate base counting. So a further development in the field is to use duplex sequencing, whereby you introduce a UMI not on one barcode, but on one strand of DNA, but also other strand of DNA. This is still cutting edge as far as monitoring of ultra low frequency mutations is concerned, and there are still papers that are exploring these techniques. So if you use duplex sequencing as compared to single strand UMI based sequencing, you can get very sensitive monitoring. Uh, so this is another paper from our group where we decided to monitor mutations such as NPM1 mutations using a single PCR-based assay. Now, the advantage of monitoring these mutations by NGS over real-time PCR is that in a single assay, you can monitor any known or unknown mutation of NPM1 in a single one-step PCR, as opposed to a real-time PCR-based assay where you have to standardize a different test for every different type of NGS mutation. Furthermore, we demonstrated that these mutations can be tracked at a sensitivity which is really, really more sensitive as compared to standard real-time PCR-based assays. But this applies only for it could be applied only for complex indels. For the rest of the SNVs, this is still a difficult approach to apply. So we tried to incorporate UMI based monitoring for blood cancers, and we were one of the first groups in the world that could demonstrate this successfully. So UMI based monitoring for blood cancers has been shown for MDS, for P-transplant monitoring of AML patients. And what we did was we used this technique called single molecule molecular inversion probe, which which consists of a number of these probes, each of which introduces a UMI during construction of a to construct a library. We asked two questions: how does this panel-based MRD compare to flow MRD, and does NGS-based MRD monitoring predict outcome who are in patients who are treated with conventional chemotherapies? So we constructed this 34 gene panel to monitor these mutations in the course of treatment using these molecular inversion probes. What essentially happens in error corrected sequencing is that every read that originates from a UMI is collected together. So these are errors of sequencing, which then you get rid of by collapsing the read, and all reads that bind to the same region of the genome form these consensus read families based on which variant calls are done. We also used a one-step PCR assay for FLT3 MRD monitoring, and we could detect, this is on a NovaSeq, we could detect SNVs as low as 0.05%, indels even lower, and for FLT3 we could go to an extreme depth. So we had several criteria for calling mutations with this assay. I'm not going to get into the details of this. The essential thing to remember is that we ignored patients with DTA mutations. We had 201 patients of AML in morphological CR. Half of them were in intermediate risk. Patients received small fraction of patients received allogeneic transplant. Most of them were had conventional chemotherapy. When they were treated with induction, you could see that 44% of patients were actually MRD positive by flow cytometry, whereas 71% of patients were positive by next generation sequencing at the end of induction. Similarly, at the end of consolidation, around 21% were positive by flow and 41 were positive by NGS. Most of the patients could be monitored using this assay. Our assay was applicable to about 83% of our patients. All right. And we could get a whole spectrum. So this is a plot that shows the distribution of these mutations in the course of treatment. And you can see that patients in mutations like DNMT3A and TET2 were much higher as compared to rest of the other mutations. But more importantly, we could successfully demonstrate that error corrected sequencing, if the patient was positive for NGS MRD, they had a much worse outcome for whether it was detected at end of induction or consolidation. It didn't matter. Those patients' outcome was worse as compared to patients who are MRD negative. The maximum utility was seen in patients who were in the intermediate risk, and there was some promise in the favorable cytogenetic risk group of patients. We also studied the kinetics of MRD, wherein in paired samples, patients who were actually positive at both time points had a worse outcome as compared to patients who were positive once and became negative subsequently. So when we compared the data between flow and NGS, what we found was that patients who were positive by both modalities had a much worse outcome as compared to patients who are negative with both modalities. And this is led to change. If you are familiar with the European Leukemia Net guidelines, now they say for AML MRD, MRD positivity by any technique is predictive of inferior outcome. So these are some more of the statistics data which show that, or that these were even on multivariate analysis, NGS MRD was independently predictive of worse outcome. We could not I apply this assay to all patients. Mainly, these were patients who had ASXL2 mutations, like around 12% of those patients. Our subsequent assay has now includes ASXL2 mutations as well. You can also do MRD monitoring using RNA sequencing. This is data from Chris Urigan's group, which shows that you can monitor patients or fusion transcripts again using RNA sequencing. This includes some really difficult to monitor transcripts as well. We published another assay called Narsimha, which can, the advantage of this assay is that you could detect mutations which are difficult to detect by cytogenetics or even cryptic, which can have multiple partners like KMT2A, like NUC98, like PDGFRA, PDGFRB, ABL1, in which you can not only identify the partner, but you can also monitor it using RNA sequencing. Moving on to the last slide, how do we improve on MRD further? Still another important constraint in the field is how you still need some amount of error modeling once these mutations are called, and it seems promising that approach known as context dependent error modeling which provides better modeling as compared to normal normal error models. I'm not going to get into the details of this, but to summarize my talk, sequencing based MRD monitoring in AML has the mainstay to become the main modality of MRD testing. The main concerns here are cost of sequencing, turnaround time, and redundancy associated with NGS-based sequencing. As of now, as recommended by the European Leukemia Net, a combination of flow and NGS MRD will probably be the best approach in the coming years. So, with that, I'd like to say thank you. Thanks to all the patients, my research group, the Himat Path Lab, my faculty, associates, and the funding agencies, Wellcome Trust, Tata Memorial Trust, and the ICMR for funding my work.